Hello. Hello.
Hello.
Hello.
Hello.
Hello.
Can you hear me?
Yes, sir. Yes, sir. Hello.
ಸ್ಟೂಲ್ ಕೊಡ್ತೀರಾ ರೌಂಡ್ಸ್ ಸ್ಟೂಲ್ ಅಲ್ಲ ಸ್ಟಾರ್ಟ್ ಮಾಡ್ಬೋದಾ ಹಲೋ ಹಲೋ ಗುಡ್ ಮಾರ್ನಿಂಗ್ ಇಟ್ಸ್ ಸ್ವಿಚ್ಡ್ ಆನ್ ಇಟ್ಸ್ ಹಿಯರ್ ಹಲೋ ಕೇಳಿಸ್ತಾ ಇಲ್ಲ Hello, good morning everyone. So at the outset, I would like to thank Manjunath sir, Shankar sir and entire team of the ENT for also the anesthesia team, Dr. Devraj, Parimala madam and team. So hopefully we get started in a positive note. We can remove the head ring. So in transoral laser surgery starts before the patient is rolled into the operating room. What is important is to make sure that the laser works before the patient gets induced, and it's mandatory to check the laser to have a very focused beam before you put the patient to sleep. So that is why the understanding of the machine, the microscope, and how it works is important, right? In terms of positioning of the patient, you can see the patient. So, can you see the patient? So we don't keep any shoulder roll or head ring. So we try to keep it flat. What we need to do is angulation right. Okay. So it's not a very sterile surgery, so you don't have to really stick to really aseptic precaution, but we try to as aseptic as possible, so that all the possible ways you can uh, avoid an airway fire can be done. So it's very important to stick to the basics here. So airway fire is very rare, provided you stick to the basics. Can we have the draper? So can we have the Mayo stand, please? Mayo stand, okay. So it's very important to have a stable. In terms of the tube, laser safe tube is ideal, but there are issues to procure those things. So we use a MLT tube, and the cuff is inflated with methylene blue, and we try to keep the cuff at least a couple of centimeters below the free edge of the vocal cord. This can come this side. This can come backwards this side. Yeah. So stable platform is useful. Keep the bed down as much possible, maximum down. To prevent any accidental damage or ಕೆಳಗೆ ಹೋಗುತ್ತಾ ಅದು? ಓಕೆ, ಕಷ್ಟ ಆಗ್ತಿದ್ರೆ ಬೇಕಾದ್ರೆ ಪೇಷಂಟ್ ಚೆಸ್ಟ್ ಮೇಲೆ ನೋಡೋಣ. ಹಾಂ, ಓಕೆ, ಸಾಕು ಸಾಕು ಸಾಕು. ಇರಲಿ, ಬೇಡ ಬಿಡಿ, ಬೇಡ, ಸಾಕಿಷ್ಟು ಸಾಕು. ಹೌದು. ಇಲ್ಲೊಂದು ಇದಾಕ್ಬಿಟ್ಟು one head around ಇದೆ ಅದು. Or you can have like a head drape to one open and one triangle. Yeah, lift. Yeah, lift. Yeah. Okay, so this is a. Okay. Fine. Next, give me a wet gauze piece. This scope idella connect ಮಾಡಿ. Suction. Yeah. ಇದೆಲ್ಲ ಕನೆಕ್ಟ್ ಮಾಡಿ. ಕೇಬಲ್, ಅದು ಫೈಬರ್ ಆಪ್ಟಿಕ್ ಕೇಬಲ್, ಎಂಡೋಸ್ಕೋಪ್, ಕ್ಯಾಮ್ರಾ ಹೆಡ್. The endoscopy shows on ಬೇಡ ಸಾಕು. On a, yeah, so you can cut the wings of the scalp inside. For the smoke evacuation and other is there. So you should have a camera to evaluate. So this is a scalp vein set we use for saline injection. So we cut the wings of this so that there is enough space for it to go inside. Can we have a scissor, please? One cup forceps ತಗೊಂಬಿಡಿ ಆಯ್ತಾ, microlaryngeal cup forceps. Okay, so you cut the wings of the normal scalp vein set. I think this is a 23 or sorry, 23 gauge. So one edge you have a little bit of wing so that you can hold it with the forceps. Okay. So ideally, if you have a liver lock syringe, you can use it, a 2 ml liver lock syringe, to connect it to that, so it doesn't. Patient is fully relaxed, right? Okay, thank you. So the most important thing, it's a close collaboration work between the ENT surgeon and the anesthesia team. So we are working in the same space. So there should be a very clear communication between the anesthesia and the operating team. So laryngoscopy is pretty standard. So what you need to do is, in terms of on the teeth, make sure the lip is away. Then suction is connected. Can you put the other suction? Right. So in terms of suspension, you can see in the relaxed field, how you do it is use the glottis, right? Lift the epiglottis. Suction. This is a 5 number tube, is it? Is it a 5 number tube? Suction. Can you hear the suspension?
Hello. Hello, Manjunath sir. Hello.
Leave it.
Hello. Manjunath sir.
Suction.
Anybody in the hall? Okay, okay. Anybody? Are you able to hearing?
Yeah, able to hear, sir.
Okay, okay. See this, Dr. Akshay, he has suspended the scope now, laryngeal surgery, pre-operative evaluation of the larynx is very important by using certain predator, namely Mallampatti, as you all know, Mallampatti, and the micrognathia, macrognathia, tongue, size of the tongue, and so on, like thyromental distance, interincisor distance, and the position of the size and the position of the teeth, whether edentulous or protruded teeth. All these are all the preoperative laryngeal predictor, wherein you can assess preoperatively before you take any patient for transoral laser microlaryngeal surgery. This is laryngeal exposure is very, very important. And once you assess the patient preoperatively for difficult exposure, to predict or anticipate difficult exposure, these are the preoperative laryngeal predictors. In that, three most important is, one is thyromental distance, second thing is interincisoral distance, and third, the dental status. These are the three most important. Now majority of the laryngologists who does this, they use these predictors to assess the laryngeal exposure intraoperatively. These are the three preoperative laryngeal predictors which make impact during the laryngeal, during the procedure, during intraoperative exposure. These are the three important which makes very important role. So in this case, as I think thyromental distance, interincisor distance was okay. It was more than 4 centimeter, 4, above 4 and below 4. It is graded like that, interincisor distance. Thyromental distance is the distance from the mental area to the thyroid notch of the cartilage with a patients in a full extension. So this you have to assess, thyromental distance, interincisor distance, and in this case the status of the dentus. It was mildly protruded. How was the exposure?
Exposure was slightly, it was a class 1 exposure.
Class 1. See, there are
Explain,
again exposure, intraoperative laryngeal exposure has been again classified into 4. Class 0, class 1, class 2,
White
class
balance.
3 and class 4. Class 0 is a normal exposure with wide bore laryngoscope. If you are able to visualize the larynx anteriorly, whole of the vocal cords with one suspension, it is class 0.
Start one. So now we have put the laryngoscope onto suspension. You can see this is the endotracheal tube. There is a little bit of bleeding, and so give me a saline, little bit of saline.
7.5 glow kodi.
ಸಲೈನ್ ಇದ್ರ ಮೇಲೆ ಕೊಡಿ, ಸ್ಕಾಲ್ಪ್ ಸೆಟ್ ಇನ್ನೊಂದು ಕಟ್ ಮಾಡಿ ಕೊಡಿ, ಇನ್ನೊಂದು ತಗೊಳ್ಳಿ, ಅಲ್ಲಿ ಕಟ್ ಮಾಡಿ, ಇನ್ನೊಂದು ತಗೊಳ್ಳಿ, ಅದು ಬೇಡ, ಇನ್ನೊಂದು ತಗೊಳ್ಳಿ ಹೊಸ, ಇಲ್ಲಿ ಕಟ್ ಮಾಡಿ,
ಆಂಟಿ ಪ್ರೆಷರ್ ಕೊಡ್ತೀವಿ.
ಸ್ವಲ್ಪ ಕ್ಲೀನ್ ಮಾಡ್ತೇನೆ ಸರ್. ಓಕೆ, ಸಲೈನ್ ಅದು ಕನೆಕ್ಟ್ ಮಾಡಿ, ಸಿರಿಂಜ್ ಕನೆಕ್ಟ್.
ಆ ಟವಲ್ನ ವೆಟ್ ಮಾಡ್ಕೊಳ್ಳಿ, ಆ ಟವಲ್ ಇದೆಯಲ್ಲ ವೆಟ್ ಮಾಡ್ಕೊಳ್ಳಿ.
ಓಕೆ, ಫ್ಲಶ್ ಮಾಡಿ, ಸಲೈನ್ ಹಾಕಿ, ಪುಷ್ ಮಾಡಿ ಚೆನ್ನಾಗಿ ಹಾಕಿ. ಓಕೆ, ಸಕ್ಷನ್.
As Dr. Akshay said, this is class 1 laryngeal exposure, intraoperative laryngeal exposure. Class 1 is wherein with the same scope and with the same position, little pressure anteriorly. Now I am putting pressure anteriorly so that you can able to visualize vocal cord lesion well, anteriorly and the anterior commissure.
What we are doing, but what sir was mentioning is we have to put the microscope under suspension and then look at the exposure, and based on that the classes are divided. So what I am trying to look at is the placement of the cuff. The cuff is well below, in fact it's very well away. This false cord is popping in. We will put a microscope under suspension and see how we are able to visualize. In terms of endoscopically, what we are looking in this process is we are going to inspect the lesion. Okay, we need to first endoscopically look then we have to palpate the lesion. You have to look the location of the lesion, whether it's what all subsites are involving: anterior commissure, posterior glottis, paraglottis, false cord area. And advantage of using a cystoscope is you can push the cystoscope down because it's about 40 centimeter. Look at the extent of the subglottic extension. So by this endoscopic evaluation, you are able to entirely map the lesion, palpate the lesion with the suction tip to get a fair idea on how we are going to approach this kind of a lesion. So now we will try to suspend a microscope and then
Class 1. Class 0, this is I was talking exactly when you are using the microscope, not with the laryngoscope. Class 0 is normal exposure without any external pressure, with a normal wide bore laryngoscopes and the position, the sniffing position, we call it as sniffing position, is joint. This is class 0. Class 1 is same thing, wide bore laryngoscope, same position,
light on,
but with little pressure anteriorly over the thyroid cartilage.
On.
Little pressure anteriorly over the thyroid cartilage. Exactly the pressure should be on the thyroid membrane, or thyrocricoid membrane, or over the cricoid cartilage. So that will pushes the larynx, anterior larynx, anterior.
So can we get the head up a little bit? Just the head slowly, head up a little bit. Just the back up slowly. Make sure the patient doesn't fall down. No. I want the angulation, no? The patient angulated. Straight angle, right? And ಸ್ವಲ್ಪ. Okay, madam, sir. Can we zoom this? Zoom, how do you zoom in? Zoom in, is it?
So I was talking to you about the intraoperative laryngeal exposure. So class 0, 1 and 2 is over. Class 3 is the position, changing of the patient's position. In spite of doing anterior pressure and with the same
Suction,
scope
can I have a suction?
and with the position, you will not able to visualize the anterior larynx. In such situation, change the position of the patient. Little what flexion type. So you change the position of the patient's head and neck so that you can visualize the anterior larynx well. This is well. In such situation, change the scope. You change the scope of the laryngoscope. So change it over to a small bore laryngoscope instead of a wide bore laryngoscope. A small bore laryngoscope wherein you can pour. Class 5, in spite of all this manual position, changing the scope and the pressure, you will not able to visualize the larynx at all, even to operate it. So in such situation, you have to keep various options available before. Illa sir, even with the angled instrument, one thing we can go ahead with the procedure or tubeless anesthesia. I think Akshay will be able to explain very well about the tubeless anesthesia and the anesthetist. I think they are able to. Akshay, over to you.
Yeah. So basically, as sir told, this is a class 1 exposure. When you just look at the suspend the microscope, laryngoscope on a microscope, you're not able to visualize the lesion left side. So we'll just wipe it off, the blood, no, and push so that the cuff is covered, right? So you can see here. So this is the lesion here. It's nicely getting rolled. It's kind of a cyst. So what we will do now is we will just try to demonstrate the especially when you are dealing with malignancy, you want to decide what type of cordectomy you need to perform for a curative resection. So you know that the vocal cord has layers. You have the epithelium, the lamina propria, and then the condensation of the intermediate and deep forms the vocal ligament, and deep to that you have the thyroarytenoid muscle. When you do a saline injection, if the lesion lifts off from the underlying structure, that means you, even if you do a type 1 cordectomy, it's an oncologically safe resection. However, when you do a saline injection, if the lesion sticks to the base, it's called a donut sign, then you know that you need to go a layer deep, that is the ligament is involved, you need to resect the ligament and it becomes a type 3 cordectomy. However, in practice, the minimum type of cordectomy I perform is a type 2 cordectomy, and this is just for a demonstration. It also helps when you are dealing with benign lesion to kind of titrate the resection and avoid damage to the deeper structures. As we had a cut one, no? Inside, right? You connect a 2 ml syringe for that. So we took one more scalp insert. So this we are going to demonstrate how to just push some water until the water comes here out. Okay. So you can also medialization. So this is a very okay. Okay. I'll just try. If I am having difficulty, I will not perform. But this is what we do in Saraswati. Can you see that? Thank you. Very good. Okay.
So subglottic pack, you can do either with neuropathies or a ribbon gauze, which is available in most of the OTs and for most of the cardiac area.
Okay. So the laser is, and we next is, the beam is there? Beam is on?
So audience in the hall, any questions during the procedure, don't hesitate to ask.
Can you switch
Please,
off
you can
the microscope light for a minute?
Anything you can ask. So to continue with the laryngeal exposure, as Manjana sir was asking what is class 0 to 5 anta, and what is the option if it is
on the
class
microscope,
5 laryngeal exposure. One is, as we said, tubeless anesthesia with a jet ventilator. You can go ahead with the procedure. And second thing is tube in and tube out technique, continue the procedures. And third thing is, if at all, if you have an angled instrument wherein the and with the angle scope, you can, so these are the various options you should surgery.
Okay, okay, good. Dot, right? So the next important thing what we discuss is to have a focused beam. You can see that? So this is defocused, it won't cut.
Please tell the parameters set for this surgery, laser parameters.
Yeah. See this. So usually there are
Cup.
four
Other
modes
one.
will be available.
Atraumatic.
The basic one is the continuous mode,
Atraumatic cup we
and
give.
the other two the difference between the continuous and the super and the interpulse is the power, and power is delivered continuously if it is in a continuous mode. All laryngeal procedures, especially maximally, these two are set and preset. This machine will be preset only in shape of the beam point. Third thing is the depth.
What is the saturation?
So the size will varies from 1
Right,
centimeter to 5
and your,
centimeter maximum. If at all, if you are
31,
using
that's fine.
if at all, if it is a pointer, if it is you have again.
It is, there is going, this case, okay, you can see small lesion, right? So you don't have to biopsy with a 2 millimeter margin or a 2 millimeter circumferential margin. It is one of my videos, like in the lecture, squamous cell carcinoma. Then the patient radiotherapy, laser excision, or a patient who gets radiated don't have cancer. What I am just trying to discuss here, do a transoral excision by and all of those, right? Patient unnecessary for radiotherapy. Good, equally good or bad. So since this is not a precise, do one thing. I'll look at the monitor. Okay. Instrumentation, lesion, and create. See, that's the little smoke there. If you have a smoke evacuator, all these things can be a cakewalk, and it's not difficult. So see, generally what happens is some as well, right? So be very as much gentle as possible when handling the. So you can see that the cyst wall you can appreciate. I will just clean it up again. Okay. Okay. Sir, onchೂರು ಒಮ್ಮೆ ಸರ್ ಒಂದು ಬಿಡಿ ಸರ್ ಜಸ್ಟ್ ಇಷ್ಟು ಕೊಡಿ ಸರ್ ಹಿಂಗೆ ಸರ್ ಔಟ್ ಆಫ್ ಫೋಕಸ್ ಇದೆಯಾ
ಇಲ್ಲ here in the focus.
ಓಕೆ ಒಂದು ನಿಮಿಷ ಬೇಟಾ ಓಕೆ ಅಲ್ಲ ಓಕೆ ಬಟ್ ಇಲ್ಲಿ ಸರಿ ಇಲ್ಲ ಈಗ ಓಕೆನಾ? ಇಲ್ಲ? ಓಕೆ, ಒಂದು ನಿಮಿಷ, ನನಗೆ ಇಲ್ಲಿ ಚೂರು ಕಾಣಿಸಲ್ಲ. There's a little bit of lag between what we see in the microscope and what gets projected there.
Akshay,
Sir?
focus on the monitor and then adjust the eyepieces for your vision.
Okay.
Adjust the eyepieces for your vision.
Okay.
Yes.
Adjust the eyepieces
Better now?
for your vision.
Okay.
It's better, Ravi Kishore? On the monitor?
Yeah, yeah.
Okay.
Eyepiece means this one. So sorry, I think stripping, I think we rarely do. I rarely do. I think sir can talk about it better. Forceps kodi. So my minimum surgery is a type 2 cordectomy. So and outcomes are pretty good.
There is no stripping these things, sir. Now most because we have to preserve the in a phono microsurgery. One of the principle is to preserve maximal preservation of the normal mucosa. In that case, the stripping is actually it is not advised. But
Can you have a wet patty?
as in a difficult larynx, when you are using a angled scissor or angled instruments, you have to go ahead with that stripping method.
See, whenever there is a blood, the laser will not work nicely. So always dab that little blood which is there. You can see the lesion better now. I'm sorry, there is a bit of focus issue. What I see and what you see are different. I'll just do the surgery and then I will. So see, I'm not grabbing the lesion. Okay, so I'm just pushing it down. I have the wet neuropathy which is placed. See, I'm just pushing it down. I'm not trying to pull or. So again, that smoke. So if you have a smoke evacuator, one hand, this job is done in 1 minute. Okay, so now once I have kind of seen the lesion in entirety, I will just again the smoke. So we can, next case what we'll do is we'll put a Ryle's tube into the nose so that will kind of suck the blood. We'll try that, sir. So you can see the very minimal charring there, no? I'll appreciate I'll show you with the endoscope what we have done. Right, so there's a little tag there now. We have not ruptured the, sorry.
So it is called mini micro flap technique.
So that's the polyp removed. So next I will just suction. So usually 3 days is
3
what
days.
we advise, sir.
Absolute white rest is 3 days, sir. And it can go up to 7 days.
I think instead of microscope, endoscope is better to see what we have done. Yeah. So we had seen what was. Can we have the laser on standby?
Standby laser.
So it's very important that, say, especially when you're doing malignancy, sometimes we may have to use monopolar cautery, bipolar cautery, and both of the switch pads are in your leg. So it's very important that whenever you are not using the laser, you ask your colleague or a technician to put the laser on standby. Because accidentally you may hit the laser button instead of the cautery button. That can lead to big problems, right? So, so these are very simple things, but it can lead to a lot of issues. Just like sticking to basics is so important in this way, right? Okay. So now we will show you the endoscopy view. So we have kept you in the dark when we were doing the procedure as such. But suction, sun suction kodi ada avugadittala. So we are going to show you the lesion now. So you can see there, right? So there is a little bit of charring there and a little bit of blood. So what is important is using a wet neuropathy. You need to dab that char everything nicely so that the healing becomes better. The chance of granulation tissue formation reduces. Granulation tissue will form, but it will reduces, the healing will be better. This is a very small lesion, but when you are doing extensive lesions, there will be a bit more charring. And the charring is also an indication that your laser beam is not focused. So that's when, cup forceps, you know that you need to get your focus again right, set the working distance, measure, adjust your microscope. So not the cup forceps. The entire thing here is to have a focused laser beam, have a clear understanding of exposure. The cutting is very simple, but what happens before the procedure is the most important thing. So the neuropathy which I had kept below to cover the cuff, I am just dabbing and cleaning this area so that the entire charring will go away, right? So there is very minimal charring here. You can see a little bit of ligament there. So we have just done a close excision of that. Okay. So that completes our procedure. In terms of once we finish this, we do this part. What we do is we take a 4% xylocaine and then flush about 2 to 4 ml on the vocal cord to reduce the cough post during your extubation. Right. So can we have a 4% xylocaine? Yeah, so we'll do a circumferential 2 mm margin. So that why we'll do a minimum, as I told, is a type 2 cordectomy. And off late what I am doing and I am seeing very good outcomes is, irrespective whether the lesion is in the anterior third or anterior 2/3, I will resect the entire vocal cord from the vocal process of arytenoid up till the anterior commissure. So by this, yeah, that's what. So when it heals, so when you do a very limited resection of the anterior third, when it heals, there is going to be a keyhole phonatory gap, right? So that will affect your voice outcomes. Like, however, when you do a straight resection from the vocal process to the anterior commissure, when it is mucosalized, it is going to be a straight mucosalization, and with good rehab, the voice is almost normal because there is no phonatory gap, right? There is going to be some alteration in the vibration, so obviously it is not going to be the God-given speech, but it's a new normal where most of the patients are comfortable. So whenever we do extensive resection, we have anterior synechiae, we see it on the camera, the patient is speaking but he is having a little thing, and we discuss with the patient an option of excision of the anterior synechiae and putting a keel in. Most of the patients will refuse, no, I am happy with my voice. So voice is an overrated thing in vocal cord surgery, when it, especially it comes to cancer, right? If it is any patient, even if it's a Lata Mangeshkar, whether the patient is going to get, if she is getting radiotherapy or laser surgery, she is not going to have a normal voice which she had before the treatment.
Professional singers ಅಂತ ಕೇಳಬೇಕಂತಿದೆ I was about to ask.
Yeah, so even if it's a professional singer, whether it's radiotherapy or laser, there is going to have some difference in voice. It is not that the radiotherapy voice is going to give back the God-given voice. No, it is not going to give that. So there is going to some fibrosis changes, but studies have shown that whenever you are doing a type 3 cordectomy, the immediate voice is better with radiotherapy, but when you look at long-term voice at 2 years, 3 years, then the voice is almost comparable. There is no head-on comparison of improved voice outcome with radiotherapy. What is important is beyond voice, how many of them have a preserved intact larynx functioning. That's very important. We are seeing a lot of patients treated with radiotherapy coming for salvage surgery. And more important, exhaust a wonderful tool of radiotherapy when you have a simple technique like transoral laser surgery where you can cure cancer in daycare surgery. But again, it's very important to stress that you have to select your cases properly. You need to cure those patients with single modality treatment. It's not good for patient to undergo laser surgery and then send the patient for radiotherapy because it's a very curable cancer. So that is why when you start the laser program, you start with lesion like this, a small lesion in the anterior 2/3, free edge of the vocal cord. A T1A lesion is a good thing to start for yourself to get confidence. And once you do a few cases, once you get your confidence, once the entire team is well set, gelled, you see your follow-ups, then embark on slightly more extensive lesions. Right? Again, so end of the day, when you treat this patient with a curative intent transoral laser surgery for malignancy, it's your responsibility to get it cured with single modality. There may be situations when in the borderline situation, I have a series of almost now 200 cases of vocal cord cancer, out of which 4 patients had been subject to radiotherapy for deep margin suspicious, not ambiguous, and those situations, but all are doing fine. None of them have recurred. I mean, they may had a recurrence in second look at 6 months, but everyone have an intact larynx and they are under regular follow-up. So that's very, very important. So what we are doing now is, so we are just instilling this 4% xylocaine, right, on the vocal cord. Yes, flush muddy. Sir.
We have a formal evaluation of this before starting the next case.
Yeah, sure, sir. Push muddy. That's enough. So we have instilled some 4% xylocaine. Okay, so we have removed all the neuropathies. Counts are okay. So very important to check because see the reason why so there is a thread in the neuropathy, but why we didn't use the thread is because when you use suction, the thread gets sucked and it causes a lot of disturbance. So that is the reason we didn't use the thing, because we are confident that even if you put the cuff in, the tube in, our anesthetist will pull it out. So that's the confidence we are working together with. A light carrier, please. With light carrier. Light steel dittala ಇಲ್ಲಿ ಹಾಕೋದು. Light. Yeah.
To add to it, Dr. Akshay, he injected 4% xylocaine onto the vocal cord, and some people use even 10% spray also, because many of the anesthetists even prefer these solution sprayed on the vocal cord is because post-operatively the laryngospasm can be prevented. That's what another anesthetist says that, and they prefer. In Bangalore, many of the anesthetists prefer to spray the vocal cord with either with the 10%, 4% xylocaine. Hello, sir. So they prefer to spray this to prevent post-operative laryngospasm, especially when you are doing a laryngeal surgeries on the larynx.
So thank you.
Any section anesthesia said
Light off.
Any question from the audience?
Thank you, Akshay.
Thank you, sir.
Nice demo.
Yeah, thank you, sir. Thank you.
Thank you.
ಓಕೆ ಅಲ್ಲ ಅದೊಂದು ಲ್ಯಾಗ್ ಇದೆ ಸ್ವಲ್ಪ, ಅದು ಗೊತ್ತಾಗಲ್ಲ, ಡಿಫ್ರೆಂಟ್ ಇದು.